Welcome to the NewlyMeds podcast. Any views or opinions expressed in this podcast are our own and do not reflect the views of our employers or affiliated organizations. This content is for informational purposes only. Always follow your local policies, protocols, and medical direction.
What is up, guys, and welcome back to another episode of the NewlyMeds podcast. Today we have something really special that Dan and I, over the last few weeks, have kind of introduced to you with the start of season 3 and the episodes that we've put out so far with some background information. But today I want to welcome Zach onto the podcast. He's a deputy chief at an EMS agency in Pennsylvania that's doing something pretty incredible. So, Zach, why don't you give us a little bit of background on who you are, why you're here, and then we'll kind of jump into the content for today.
Absolutely. Again, my name is Zach. I am a deputy chief at a service here in Pennsylvania. Today, we're going to talk about a pilot program that will be starting in the next week or two for pre-hospital antibiotic use in sepsis patients. It's the first of its kind here in Pennsylvania, from what I understand, and we're really excited about it. We used a lot of data and a lot of research to develop this program, and we're very excited, and we think it's going to save a lot of lives and help a lot of patients along the way.
Absolutely. And so, guys, just to give you a little bit of background data for where you're listening in and depending on where you work, kind of which side of the house, too, whether it's in the hospital or pre-hospital. Pre-hospital sepsis affects a lot of patients that we see. And data shows that patients that we identify with severe sepsis in the field are associated with a 20% mortality rate. If you know anything about mortality with EMS and some of the things that we see in the nature of our calls, that is a markedly high number. It carries a ton of associated deaths with it. And it's something that we need to identify in the field, but not just identify and report, but we need to begin treatment on it. And so that's sort of why we're here talking about this today. And we want to dive into really why this is so important. How can we identify it? What are the things that we can do to absolutely treat it? And Zach mentioned the pilot program in Pennsylvania is the first of its kind in that state. How can we garner some traction to not only start this program, but make it go national and really save a lot of lives? So before we get into the content, Dan and Zach, I want to throw something at you that we probably see all the time in the field. You get dispatched for a priority sick person. There, we say it's an 80-year-old female, just a complaint of malaise. You get on scene, you assess her. It's an 80-year-old. She's kind of frail, thin. You kind of can picture this in your head because it's a lot of the patients that we see kind of present like this. She says she hasn't been feeling well for the last couple of days. We're right in the heart of flu season. You auscultate some lung sounds and you hear a little bit of rhonchi. She's a little bit pale, slightly tachycardic. Blood pressure is a little bit on the softer side. She's a smaller elderly female, so maybe you're not concerned at this point. You feel her skin, it's dry, slightly warm. You're not appreciating anything that's uber concerning, so you get her out to the truck. All of a sudden, she starts to have this increased altered mental status. You reassess her blood pressure, and it's declined significantly at this point to a map of 59. What are you starting to think, and why is it so important to identify these patients possibly immediately? And for the listeners, you probably know what we're going to say, what we're thinking based on the episode title. But Zach, Dan, why don't you walk me through some of the points on this call with that brief information and what's concerning to you?
Yeah, well, I'll start with that. First of all, I did want to also echo how excited I am to have Zach on here with us to be able to have this discussion. And I am extremely looking forward to being able to hear more about this program. We've obviously talked about it a little bit before we started here, but to get into the nitty and gritty of that, I'm super excited to be able to have this conversation with both of you guys. If you listen to the podcast, you know where I stand on this. I am a broken record when it comes to history taking and making sure that we are doing good, full, thorough assessments. Being able to understand not just that patient's complaints, but where she has been as far as her place of health over the past day, 2 days, week, looking around for any cues and clues that might kind of give us a little bit more in-depth information as to what it is that we're looking at and what it is that's causing the decline that we're seeing. So I think, again, it's no surprise what it is that we're talking about. So I'll just come right out and say it is from a history taking and an assessment standpoint. We need to be looking for those signs of infection. We need to be looking for any possible source of infection. We need to be considering maybe they went to the doctor and maybe they already had some type of infection. Maybe they had a pneumonia, maybe they had a UTI, nothing too serious at the time, that they were sent home outpatient on some PO antibiotics. And, now they are at a point where that has progressed. Looking at their medications, do they have a recent prescription for baclofen or some other antibiotic that might, even if they aren't able to tell us what's going on, and maybe there's nobody there with them, maybe those types of things can cue us into what's going on. So I know I'm a broken record when it comes to it, but I think history taking and the assessment is step number one, and one of, if not the most important step that we can take when it comes to creating a list of differentials for these patients.
Absolutely, and I think that's a great point. That background information is so critical to understanding these patients. Zach, take us through what you think and sort of your perspective on this patient and maybe some of the immediate things now that you're starting this pilot that come to your head on how we can manage them, maybe in a way that we were never able to before. I know you've been in EMS for quite some time, so you've seen really the spectrum of care of how we've grown and the interventions that we can and can't do are ever evolving. So, what do you think about this?
Yeah, absolutely. I think it's extremely important to, like Dan said, obtain a good, solid history on the patient, find out exactly what they're sick with, because something this question does, and this scenario does raise, is actually talking about antibiotic stewardship and are we giving it appropriately. So the direction that sometimes people take is, you gave the example of, didn't say that she had the flu, but it's flu season,
Yeah.
so, asking her, did you go to the doctor? Did you get looked at? Were you diagnosed with anything? Actually, like, were you diagnosed with influenza, some kind of infection, something like that? And then going from, okay, now is this a viral infection or did this turn into a pneumonia and become bacterial? Because one point of learning that we had to use going through this pilot process and the education is sepsis isn't just bacterial, right? Now, we frequently, as EMS providers, will see um, bacterial due to, especially like our big two, UTIs, pneumonias, right? Those are the big two. But taking it even further, complications from COVID, the flu, anything else kind of in that viral field, and realizing that yes, we're providing care, but those antibiotics aren't, that's not what that's for. And that is trying to teach individuals the difference between a viral infection and bacterial, and kind of the steps to what we can identify. So like, again, backtracking to the flu type scenario, did this patient get diagnosed with the flu? She's not getting any better, but she started developed a high fever, altered mental status. She's coughing up yellow tinged sputum. She's got bronchi in one of her left lobes, and she's going down the path of, yes, this started viral, but now we've become bacterial, and um, that is where our antibiotics are going to come into play. And again, it's very exciting because a very large portion of this pilot process and kind of selling it has been the antibiotic stewardship and the training that kind of goes along with that as well.
Absolutely. And I think that raises a great point. To what we see in the hospital, as well as someone who's been able to be fortunate enough to work as a paramedic and continue to function as a paramedic, but also on the nursing side of the house, we see a lot of septic patients and we see them as after we get them from EMS. And also we're initiating some of the sepsis care in the hospital. And the antibiotic stewardship is huge, whether it's pre-hospital or in the hospital. When we have a number of resources of lab and pharmacy, and we're able to actually grow these cultures and see them, which I know, Zach, you guys probably had a lot of education on the importance of cultures, but in the EMS world, we're not really seeing what those are actually growing and understanding how we go about the antibiotic use on it. And so that leads me to what I want to get into with this episode with you, Zach, is the meat and potatoes. Tell us more about this pilot Tell us some of the things that you used to actually initiate it and start it, how you went about figuring that this was so important. One thing that I want to point out that you and I have discussed on is a study by Antevi that showed about 1,300 patients, a little bit more than that actually, in one EMS system in Florida. There were 1,300 plus or minus a couple sepsis alerts. That's a significant amount of patients for one EMS system. We're talking about just one system. So it's something that we see nationally in a huge capacity. So how did you realize this was something super important to you, Zach? And what was the actual process for getting it all the way up to where you're at now, to where you're rolling this pilot out in about 2 weeks, you said? What are the steps? And give us some of the background on it, because it is so vitally important to EMS.
Right. So I will. I'll kind of go back to the beginning. So I've been a paramedic for 16 years now, and when I started, I very quickly realized, we go through school and they don't really touch on it as much as they do strokes or STEMIs or trauma, anything like that. But then when you start doing the research, and I started looking into it and talking with my mother, who's also a nurse, how bad sepsis is, and that because it's not a glamorous topic, people kind of look at it by the wayside. So going in and actually studying and being like, oh my goodness, this is killing a lot of our patients, and probably the most of our patients. So through the years, trying to develop something and come up with a very broad idea of what I wanted it to be, and going to organizations that I worked for and pitching like a hey, how can we consider doing this? Um, was very difficult to do because there's different processes and different ways throughout regions and counties that they do pilot programs, and nothing really ever stuck. So the service I'm with now, I went to my director one day shortly after I came into my role, and I said, something that's always been on my mind and always wanted to do was try to introduce antibiotics in the care of sepsis patients. And he's like, "All right, let's do it." And I was like, "Oh, okay, that's great." And he was very supportive from day one in doing it. He had a lot of experience with trying to pitch pilot programs and had previously worked at a regional office, so he kind of had some knowledge of how that all works. So between him and I, he was a huge resource and a huge help. We were able to kind of get this off the ground. Now it wasn't necessarily an easy process because our first time we pitched it, we were denied, but it wasn't a no, we don't want you to do this at all. It was here's what we'd like to see first. And the first part of it was getting our local hospital system on board with us doing blood cultures, which is a huge proponent of this, huge part of this whole process. So we're able to work with our local hospital system, work with their lab, get training through them, and then they said, "Hey, we're okay with you guys obtaining blood cultures in the field." And we came back with that knowledge to our regional Met committee and said, "Hey, this is their plan. We already have the hospital on board, and here's where we'd like to go from there." And then we got approval through the region. Then we took it to the state, and the state approved it with very little pushback. They were extremely supportive, and that was awesome. We did originally pitch to use cefepime instead of ceftriaxone, but we kind of had to take another look at that and say, I think maybe ceftriaxone would be better pre-hospitally, in the sense that you can give it quicker, you can give it over 10 minutes as opposed to 30, and it's not quite as intense as cefepime is. Even though cefepime does have that pseudomonas coverage, which is great, ceftriaxone is still an excellent broad spectrum antibiotic that can be used. Along with that, the ceftriaxone was part of this local hospital system, like initial sepsis bundle. So it worked well. It worked better for them, to be quite honest with you as well.
Yeah, absolutely. And I think what you said really resonated with me on the sense of how deep this really goes. And so something that EMS has never done has been drawing cultures. And Zach, I know you learned in the process, obviously, something that they don't go over at all in paramedic school. You need two different sites. They need to be
Hmm.
prepped a very specific way. It's not your run of the mill swab the alcohol, stick them. it's set up in a way that we want to get the cleanest sample possible. And in an EMS world where we do very few things in a clean or sterile-ish environment, the learning curve on that had to be massive. And I'm sure that was a little bit of the feedback that you got when you were setting this up. So walk us through the education that you received on drawing those cultures in the field, because I know, or at least I can assume, I'm sure some of the negative feedback that you got was there's no way EMS can do this. It's too much, or maybe a little bit of pushback because it is hard to do, but in no means is it improbable or impossible. I think it's absolutely probable. And then also tell us a little bit about how you guys learned maybe we should draw the cultures before getting the antibiotics on board.
Yeah, absolutely. So education obviously was a huge piece to this whole project, and that was obviously our first piece of that. So we sat down with this local hospital and their phlebotomy team and the lab, and got some education initially. We did kind of like a train the trainer course with the majority of our folks. There's obviously you can't get everyone to make every single training that you have, but then they were able to after practicing on practicing drawing labs like you would in medic school or AMT school. They were able to, we beat it in their head pretty hard at how important that was, and how that sterility and that cleanliness is for these samples and this program in of itself. So we've done pretty much like 3 sets of training. We did the original in-person training with the lab. We then did at our annual review, we did another training with it, and then we have our third round of training, which is like everything good comes in threes, right? So like third time's a charm. We hit them with it, and then like I said, once that's complete, we're going to actually launch the program in its completed form, and kind of move forward from there. But it was so big and so important to communicate it to some of these folks who are used to drawing just regular labs on folks, like you said, just a quick alcohol swipe, and you get a couple yellow tubes, and you move on from there. And then teaching them that no, this is a little bit more delicate of a process, but then explaining the why as to why it is so important that these samples stay clean and sterile.
So along with that, something that I want to ask Dan, and then Zach, I'm going to throw the same question to you. So don't get it out of your mind just yet. It's so important to obtain these cultures and then initiate that antibiotic therapy. But before we even do either of those things, how do we start identifying what patients meet the criteria for sepsis? And so for me, in the pre-hospital and the hospital setting, I have seen quite a few different pieces of scoring material, I would say, on how to identify these patients. So, off of vital signs, especially in the hospital when we have access to lab values, looking at a lactate, looking at some other lab values that might be abnormal at identifying why a patient might be either a sepsis alert or, some form of maybe they're in or going to be in septic shock. So I know we hear a lot about SIRS or SOFA or the Q SOFA. Dan, at your service, what do you use? How do you identify these patients that might be suffering from pre-hospital sepsis or septic shock? And then Zach, tell us what you're using in the pilot.
Yeah, absolutely. For those that don't know, this was actually one of the points that I did want to bring up as well. So at my service, we do use SIRS, which is for those listening that are not familiar with these. SIRS would be the systemic inflammatory response syndrome, or something to that effect, and that is simply the easiest way to look at that criteria. Do they have a temperature? Do they present with tachycardia, and do they present with a source of infection? You can throw an elevated respiratory rate in there as well, and it really is that simple from a standpoint in which your senses should be raised, that you should have that increased index of suspicion that this person is a candidate for a sepsis alert. So I know that that's what we use at our service, being the SIRS criteria. And I know we were actually just talking about this at work the other day. We do consider stuff like SOFA, Q SOFA as well. But as far as the actual by protocol for a pre-hospital sepsis alert or activation of the hospital, that would be SIRS on our end. And I know we were talking about this as well, is that that is something that our system from a pre-hospital standpoint is, I don't want to say lacking, but is not as aggressive on. And that I know personally, especially doing the research for these last couple podcasts, is something that I would love to see us take a more aggressive stance on. But I know that that's where we currently stand now. So Zach, if you want to kind of lead in with what your pilot is using for criteria, both for an alert as well as for your next step of interventions with the bundle, as well as I know the cynic and analytic brain in me always kind of comes up with the counter arguments that I'm sure that you heard pitching this pilot and getting this approved. So maybe if you want to also speak of wrapping out with the labs, what is the importance of getting those cultures early? You know, I see the arguments being, not being in the room with you when you had these conversations. I see the arguments being, oh well, they'll be at the hospital in 15 minutes. Why even do any of this, right? So I'm sure that you had some research that proved why this is vital in doing that.
Absolutely. So for our pilot program, we're using like a modified QSOFA is what we're calling it. It's kind of in two steps. So the first step is either they have to have either a suspected or known source of infection, and that they have to have a temperature of greater than 100.4 or less than 96.8. If they would meet either one of those, the next tier they would have to have two of these for, which was altered mental status, a heart rate greater than 90, respirations greater than 20, as well as a systolic blood pressure of equal to or less than 100 systolic. We kind of used a lot of that, and I'll kind of explain each one, right? So the temperature thing, the reason we said temperature or known or suspected site is because how many people get fevers, and especially in nursing homes and at home, they go and they treat it with Tylenol, right? Because if we go and we pick up grandma with a ripping UTI and she just had Tylenol an hour ago and now her temp is 99.8 by the term of some sepsis criteria, well, she wouldn't meet it because her temp is not above that. So we said, yes, that's a great, obviously, an elevated temperature is a huge red flag. But if we know that she does have, yes, grandma was diagnosed with a UTI, or this is how she normally acts when she has a UTI, or we all by this time know what UTI smells like. Those kind of history obtaining items are enough to then again proceed to step two, which is the respirations, the heart rate. Again, heart rate, people can say, well, they're not tachycardic at 90, 92. Yes, but how many of our patients are on beta blockers, right? Whereas 90 is tachycardic for them. They're used to a heart rate between 50, 60, maybe as high as 70 on a bad day. But 90 for a patient chronically on beta blockers is pretty high. So looping that in there, again, the blood pressure being less than 100, 100 or less, I believe is very important, because when you go 90 or less, you're starting to get to a point where you're trying to play catch up. And a big point of this pilot program is to catch the people that aren't necessarily in septic shock yet, that are going in that direction. So catching them early as opposed to later. Whereas, like I said, you've got a lot of catching up to play after you start getting 90 and below. And that was, again, vitally important. We considered the use of end-tidal CO2, but again, we didn't feel that it was necessary. At times, you're going to have, depending on how people breathe, if they're mouth breathers, nose breathers, you're going to get inaccurate readings. We have so many people who, though we try to educate, don't realize that if you put the oxygen of a end-tidal nasal cannula above a certain liter per minute, it completely throws off your results. So if you have that patient on 6-8 liters nasal cannula, well, your reading's probably not going to be accurate at that point. Again, there's other things with heart failure. And again, if you're starting to get an end tidal reading that's lower in the 20s, low 30s, you have some serious cardiac dysfunction, and you're probably going to see the hypotension along with that as well. So we just didn't think the end tidal was really needed. And those other signs were really important uh, in the meantime.
Yeah, I think you raise a great point, and it's something that I have been particularly passionate about as going through quite a bit of education to get to where I am now. Is we see a lot of looking at the chart and the numbers, and for some odd reason I start to see a lot of especially newer clinicians where they train you in school. You could say a million times in school, look at your patient first, but then they hit you with the make sure you're checking this lab value and this vital sign and doing this and doing that. The criteria that you're using pretty much allows for, I don't want to say strictly because it's not, but a large amount of clinical judgment. And so, Zach, some of the things that you said that I just don't see enough of is the investigative process, which Dan and I talk about on this podcast all the time. But is my patient on a beta blocker? If they are, they're not going to be grossly tachycardic. How many patients do we see, even in the hospital, but out in the field, that, our patients are not calling 911 as soon as they have a sore throat? They are waiting and waiting and doing a lot of self treatment. So it's not just at the nursing home where they get some Tylenol. People are taking it over the counter and they're like, I think it's just the flu. And they don't realize that maybe this disease process is progressing. And so they might not have that temperature, as well as the cold sepsis, which is something that we could talk about on a completely another episode. But you mentioned that the temperature not having to always be at that febrile level. It could be cold sepsis. And that's something that we're not going to dive too deep into, but is just as vitally important. And then same with the blood pressure. Patients that are on that beta blocker or on calcium channel blockers for some other disease process, that's contributing to this patient's presentation. And so adding all of that in, it's so important to really understand the whole picture. So Zach, thank you for bringing that up. And that's why I think these criterias are really important to use to really guide us, but it's more important what we're seeing in the field and that whole big picture. So off of that, I kind of want to talk now more about the treatment level with not just the antibiotics in your pilot, but I'm going to throw a situation at Dan and you, and we'll go in the same fashion again. Dan, tell me what you would do, kind of what your thoughts are. I'll go over my thoughts a little bit as I present this case. And then Zach, tell us with the pilot, kind of where you guys are going in this direction. So I want to just briefly introduce the Surviving Sepsis campaign. It's something that's been a real driver of sepsis treatment, not only pre-hospitally, but in the hospital, really sepsis in general. I think it's really important to differentiate the fact that a lot of people confuse sepsis as a blood infection. I don't want to mess this up, so I'm going to pull up the actual definition here. Sepsis is a life-threatening condition that happens when the body's immune system has an extreme response to an infection causing organ dysfunction. So yes, sepsis may be in the blood, but no, it is not a blood infection. It's causing organ dysfunction. And I think that that's something that I hear in EMS, but also in the hospital is it's like, oh, someone's septic, they have a blood infection. And there's a difference between septicemia and sepsis. Again, that's getting into the weeds here, but I think it's important to understand that definition. As far as surviving sepsis goes, the campaign says that if shock is present, immediately administer antimicrobials within 1 hour of recognition. And if sepsis is possible, again, immediately or ideally within 1 hour of recognition, we are administering antimicrobials. If shock is absent, but we are definitively or probably in the sepsis range, we want to, again, immediately or ideally within 1 hour of recognizing it, administer antibiotics. And so, again, someone does not need to be in this shock state to get those antimicrobials or biotics. And then if we are thinking sepsis is possible, they are saying in the Surviving Sepsis that a rapid assessment of infectious or non-infectious causes or of acute illness should be done. And then within 3 hours, antimicrobials should be given if the infection persists. As far as vasoactive management, norepinephrine should be something that is now getting more and more common in the pre-hospital realm, but also in the hospital is now being used for first line for many things. But as far as sepsis goes, norepinephrine is our first line vasopressor, targeting a MAP of 65 plus. The rest of these mainly have to concern the hospital, but it's considering invasive monitoring with an arterial line, not doing peripheral vasopressors, adding vasopressin, and then your inotropic support. So your dobutamine or epinephrine. But pre-hospitally, that doesn't have a huge place. I don't think a medic maybe in a long time is putting in a arterial line on purpose and using it for its intended purpose. But I will step off that soapbox. We're going to go back to the patient that we had at the beginning. So an 80-year-old female, you guys already heard her. In my mind, when she gets into the back of that truck and she starts to exhibit those signs of shock, that tachycardia, the hypotension, the elevated temperature, I want to initially start my fluid challenge. Again, looking at that 30 milliliters per kilogram range. As far as EMS goes, we're probably not going to get an appropriate fluid challenge in that patient within the time frame that we're getting to the hospital. So I think it's vitally important to establish an IV, get a fluid challenge going, but also understand the context of this. If my patient is sick enough to need a vasopressor, I should probably get that on board sooner than later. It is a fairly fast process that a fluid challenge is not going to work. And so I don't want to say there's a definitive number. It's sort of just, again, clinical judgment. But I know if I've put a liter of fluid in the patient and they are continuing to have a decrease in blood pressure, I don't think that that preload and that fluid management is going to correct this hypotension. So at that point, I may be thinking a little bit further. Getting the antibiotics on board, multiple points of IV access, and then initiating that transport is just a real brief, quick, down and dirty thing I want to do. And then before I kick it over to Dan, something that I am very passionate about, especially more so now, I have not been in EMS for as long as Dan or Zach, but in the time that I've been in EMS, I think that the old way of teaching, and we sort of see it with the use of a BVM, is that we're really limited on our resources. They're like, you can use the CE grip and all this. More often than not, we have a lot of people helping us on a call, whether it's the fire department or police or orientees, extra hands in the back of the truck. We're really not as, we are short staffed, don't get me wrong, but we're really not in a era of, oh my God, I'm all by myself. I have all these things to do and I can't do them. So the only point that I want to make here is use your resources. And so Zach, you talked about getting the cultures, getting multiple IV sites for those cultures is going to be appropriate, but it's not like it's improbable. You can get an IV as a paramedic. You have help of maybe other paramedics that can get an IV. And if they can't, you have help if you need it to just call the fire department, or if they're not already there or police isn't already there, they can do some of those ancillary tasks that someone trained at the BLS level, which every police officer and firefighter is, and EMT for the most part are trained there. Maybe you just need them to hold a bag of fluid or grab something for you or take a temperature for you. I think we're in the era of, if somebody doesn't know how to take a temperature, we have other things to worry about. So you do have the help and utilize it. So as far as me, that's kind of the soapbox I'm on. Dan, what do you think about with that patient? How are you going about a treatment tree? And then we'll hear a little bit about the pilot from you, Zach.
Yeah, absolutely. I think we all had drilled in our head the 30 mils per kg fluid challenge. And I think when we were talking earlier about clinical judgment, I think that also needs to be in the back of our head that in a perfect world, sure, our patients only have one medical issue, and that is the issue at hand. It is the sepsis or pre-sepsis, and that's the only thing that we have to consider. Yes, we need to get these fluids on board. But in the world that we live, in the real world, these patients have other problems. We need to be making sure that we are not flooding these patients out when they have, renal impairment, or they have heart failure or something to that effect, in which they're not able to appropriate that fluid correctly. And now we're causing ultimately more harm than good, which just further supports that, yes, if we need to get norepi or some type of vasopressor on board early, we need to do that early and not wait, not hesitate to pull the trigger on that. As far as the patient goes, it's exactly that. We're going to get, you kind of hit all the points there. We're going to get early access. And when it comes to crew resource management, like you were talking about, I think it's incredibly important to make sure that we are using all of our partners the best that we can. I know where I'm at, we're lucky enough that at the EMT level, they can start IVs. They can start an initial fluid challenge. I think they have 500 mLs. They can do a lot of the things that I know where you guys are that are kind of advanced EMT level interventions. So don't hesitate to have those individuals jump in. But yeah, as far as this patient goes, Will, I think you hit all of the points there that we're going to try and get bilateral large bore IV access if possible. We're going to get the fluids on board early. And one thing that I'm sure Zach will bring up as well is that early notification to the hospital, making sure that it's not that, you know, we're 5 minutes away and I'll just call them when we get in the truck and start driving. If you have the ability to call them as soon as your kind of red flags start going up and saying, hey, we're going to start going down the sepsis bundle for this patient, we need to be notifying the hospital so that way they can get the resources ready to make, you know, you have that. Will, you brought up the 1 hour benchmark there. If we are not giving antibiotics in the field and we have these maybe it's not 5 minutes from the hospital, and maybe we are in a service that we are 30-45 minutes from the hospital plus a 15-minute extrication, you know, there's our hour window right there. So the earlier we can notify the hospital and having that relationship with the hospital so that way they have those antibiotics ready, they have that bundle ready to go. I think that's one of the most important things. If we are not in a pilot program, if we're not doing the things that Zach's agency is about to do here, I think that's one of the most important things that we can do from a long-term stance would be that early notification. Otherwise, yeah, absolutely. Fluids, vasopressors as needed, and go from there.
Zach, take it away.
Yeah, absolutely. I do want to backtrack though, very briefly, to what you talked about the sepsis bundles, the surviving sepsis, and how you made the point that it recommended antibiotics within 1 hour of identification. And I don't mean to be speaking out of turn, but I believe that is based on like hospital standards, correct? Like this is
Correct.
so I got this pushback from someone about like, well, the sepsis campaign says as long as it's within 1 hour, they're going to be doing okay. I said, yes, it's 1 hour from identification. In the hospital, your patients are closely monitored and usually checked on every hour, even at most every 4 hours. And at that point, you still have some time. Well, when do we see them? We see them when it got really bad, right? You're not seeing them in that short 4 hour window. You're seeing them, they've probably been septic for 2 days now, and they're starting to go down the drain. So that 1 hour, just that's not even relevant to, in my opinion, not relevant to pre-hospital because you we're identifying them very late in the game. And again, we're getting to the point where we're starting to approach septic shock. Like we're past just sepsis, septicemia, sears, whatever it might be. We're finding them very late in the game, which is why the antibiotics early are so important because we've already bypassed that window that program represents. When it comes to fluid resuscitation, our program is recommending 30 mLs per kilogram. We originally were going to go with LR focused for a variety of different reasons. We had to shift back to normal saline primarily because ceftriaxone and LR do not play well together and they precipitate. Um, so that is why we went back with normal saline. Now, granted, you can start a line and then give LR. That's not a problem. But for the sake of the pilot and making sure we don't confuse people or cause the patient any harm, we're saying normal saline. And then, like I said, the providers can use their judgment if it would be prudent for some extra. Some signs and symptoms. You brought up a great point that there's times where we're giving some fluid and we might, of course, we're not going to be able to give 2 liters, right? There's very little time unless you're deep in a rural area. 2 liters of fluid's probably not going in your patient. So part of the education again is determining, yes, we need to give a fluid bolus, but at what point do we want to start early vasopressors? I'm very fortunate that I have Levofed on an IV pump that I can use and use it soon. So teaching folks, like, what are we looking for, right? Absence of a radial pulse. You're not peripherally perfusing. What's another sign? Putting a pulse ox on, I can't get a good reading, and I don't understand why. That's because they're not peripherally perfusing. The altermental status, obviously, you're not perfusing up there. Um, you know, skin condition, all those things that they teach you in class of recognizing shock and somebody who's very quickly decompensating. I would say that again, I put a lot of trust in my folks to make the best clinical judgment. I have a great team, and I am fully comfortable with them making the best clinical judgment, which is why this program I think is going to be really great because it will empower them to truly make the clinical decisions of when to do some of these interventions or when it's going to be appropriate. But again, I think, like you said, it's extremely important to not only give fluid early, but start vasopressors early if you need them, and then being able to teach your folks and identify, like, okay, fluid is not going to fix an absent radial pulse. Fluid is not going to fix somebody who's barely responsive. Fluids that it could at times, sure, but you don't want to be behind the eight ball. And especially if you're hypotensive in the 80s, 70s, and your map is in the toilet, you're way past just a little bit of fluid fixing them, and you need to aggressively start your vasopressors early.
Yeah, I couldn't agree with you more, Zach. And the next point I want to talk about is probably where you got, I don't want to say hung up a little. I don't know the entire process of what you went through, but as far as the hospital side of things go, I do understand some of the things that we care about. And I agree with you. In the Surviving Sepsis campaign, our patients are closely monitored. So when we're suspecting sepsis, it's based off of lab values that get drawn every single day. I work in the CVICU where our lab values are typically drawn multiple times a day. We can draw an ABG pretty much whenever we want. And so our patients get monitored at a very, very frequent and high level. And so, like you said, and like I said it a little bit earlier in the podcast, these patients are not calling 911 at, my throat's starting to get a little sore. Maybe I have a pretty bad infection going on, or, I have a cut that I am just going to ignore, or any of that. We're seeing these patients that are pretty sick, and that have been pretty sick for some time. One of the things that we talk about in the hospital is this perfect sepsis bundle. And I'm sure that you heard about this a little bit, Zach, going through the pilot. Tell me how that went into some of the decision making you make, a little bit of the feedback and maybe pushback that you guys got. And then I want to hear from you a little bit of the data on why this is so important. Because as someone who works in the hospital and EMS, I see both sides of the world. I get to see this
Mhm.
pre-hospital system, and then I get to see these patients carried through into the hospital and this longevity of care. So when I talk about this perfect sepsis bundle, it's a very hospital driven thing because you guys are not getting lab values in the field. However, I'll walk our viewers through it and our listeners in case they don't know. So when we suspect sepsis and septic shock, we're doing this perfect care bundle. The very first step is to measure a lactate level and obtain blood cultures immediately before we administer our antibiotics. That's like a huge thing. If you fail any one of these, you fail the bundle. It goes on. There's a lot of things that carry on the managerial side of hospitals with the bundle. So it is something that we care about deeply. The third step then would be to administer your broad spectrum antibiotics, begin your immediate rapid infusion of 30 milligrams per kilogram of a crystalloid if the lactate is greater than 4 or hypotension is present. And then your fifth step would be to apply vasopressors if patient is hypotensive after that initial fluid resuscitation to maintain a MAP of greater than 65. We kind of talked about a few of these already, but I understand from working both sides of the house how lethal sepsis can be. And the other thing that I understand, Zach, that I want you to talk a little bit more about is every episode of hypotension that somebody has when you are suspecting sepsis, their mortality goes up pretty significantly.
Mhm.
So the question I have for you is, it's going to be a little bit redundant. Why the heck are we not treating this already? And exactly your point with this pilot is, why is this so important if this is probably what's killing the most of our patients, which I think all three of us can agree it is.
Yeah, let's start back at the actual sepsis bundle. So that was a huge, I wouldn't call it a pushback, but that was a big point of how are we going to communicate with the hospital on how these processes in this bundle was accomplished. Because basically we're doing that we're doing the sepsis bundle now in a lot of ways. We have a form that we created, um, that basically not only walks you through the pilot program, but writes down times for the hospital. So they have everything from where the first set of lab cultures were drawn, what the location was, what was the time, where the second set of lab cultures were drawn from, what time the lactate was pulled, what time it was put on ice, and what time the fluid was initiated, how much fluid was initiated, when the fluid was stopped. So again, it's documentation heavy on the provider side. It is a lot, but it will help the hospital in the end be able to complete that sepsis bundle from an administrative side, which is, like I said, a huge point of it, and be able to fill that out. And again, like I said, it also, when did we start the antibiotics? Did they have a known allergy? So we have a form, and then that form gets passed off to the hospital because they have to fill all those things in themselves when it comes to their sepsis bundle. So basically, like I said, we're almost in a lot of ways doing that sepsis bundle, but we have to make sure, again, a huge part of the pilot is making sure we document that correctly and show that we're pulling these cultures before we start that antibiotic. There is some research out there and some data showing that that's not always the case anymore. I really didn't look into that too much because I was very focused on the fact that we were getting the cultures and giving the antibiotics. I like I said, I'm not saying there's no merit to that. There's absolutely merit to it. But for the sake of our conversation, uh, people knowing that yes, we give a broad spectrum antibiotic to start, but then those cultures are important because that'll tell you what exactly you're then going to treat. What antibiotic am I then going to tailor to giving to treat that disease process and that bacterial infection? Because again, ceftriaxone is great, but it's very broad. It's very broad, and once you can kind of get a little more specific, you're doing that. I like to kind of say like ceftriaxone's the army, and then the more specific antibiotics is like your special forces who are going in and then taking care of the issue at hand, if you will. I think is a decent way to explain it. But those cultures are extremely important because if they're tainted, you're going to get a finding that's off because there's germs, there's bacteria everywhere, and then like I said, getting those is so important to accurately treating the patient's disease process that they have.
So, Zach, you mentioned all the things that you guys are doing to really care for these septic patients. And it sounds like a lot. It sounds like we have to get these clean, tedious blood cultures. It sounds like we need to put these cultures then on ice for the hospital and multiple IV points. And then now we're giving an antibiotic that can only be compatible with saline, but I'm in my mind, a pretty solid and sound clinician. If somebody's septic, they might be already borderline acidotic. I don't want to perhaps worsen that. So I'll probably start LR in another line, but that takes some time to spike that bag. And so as we progress through all this, to me, it seems like quite a lot of things have to get done here. How quickly can you guys do all this? What was the importance of saying like these are tasks? And I think that's the one thing we see in the hospital a lot is, there's a lot of tasks that have to get done on a day-to-day basis. And as a nurse, if I let my tasks run my life, I feel like patient care doesn't get done. So I don't worry about the tasks. I worry about my patient. Is this screening scale that's supposed to be done every shift going to fix my patient who is in the room actively in a peri-arrest state? No. Do I need to go to my computer and fill that out because it's due at 10 a.m.? No. But I think if you get in the mindset of, I need to do all these tasks before I ever treat my patient, it probably exacerbates the problem at hand. So tell me how you guys are getting through this quickly and appropriately while not forgetting to actually perform patient care.
Yeah, absolutely. So we're very fortunate. Our system's built on a paramedic fly car, chase car, whatever you want to call it, as well as following not just BLS trucks, but primarily intermediate trucks a lot of the trucks have two intermediates on them, which is great because the intermediates can draw the cultures themselves. They were included in the training process. So you can have a paramedic on scene, talking with staff, talking to the patient, assessing the patient, uh, given the like, hey, this we're going in the direction of sepsis. Now I have two AEMTs who are pulling from cultures from two different sites as we're determining, hey, we're going to then give this antibiotic, and you can be doing all of this, in less than 10 minutes. You could be on scene, assessing your patient, do all this stuff, starting your antibiotic, and moving to the hospital with a good, well performing team in less than 20 minutes. Um, but that's how we kind of built our deployment model, was having three people on scene as a force multiplier, even whether it's an AMT, a paramedic, or an EMT. Like, that extra set of hands can be doing something, right? That could be spiking a bag, that can be obtaining a set of blood cultures, that can be documenting on our pilot form. That there's so many different things that can be done, um, with a third person on scene. And even like I said, all those people trained to draw labs and to administer that medication is huge and important. And also, I believe we do a very good job of empowering our BLS providers to do these assessments and know what criteria to use, that they can be asking the questions while the paramedic and the AMT are performing skills as well. And I think that's a huge thing, is reminding our BLS providers that sometimes fall to the wayside, that a lot of our assessment skills, our objective skills of, what we see, what we say, the questions we ask, are all the same across the whole spectrum, from a nurse down to an EMT, are all very similar. The difference comes is how we react to the information that we get, right? There's different things that we can do, as an AMT, as a paramedic, and things like that. So trying to really use their assessment skills and clinical decision making as part of that team effort is also huge to making this process be successful. Because again, it just can't rely on the paramedic just because they can give the antibiotic, but again, the whole team gets involved and asks the questions, and everyone's kind of we're kind of taking the pit crew CPR type deal, but applying it to sepsis in a way, if that makes sense.
Yeah, it does. And Zach, something you said I think is so true. And for some odd reason, when I got into EMS, I feel I was very empowered as a EMTB. I was pushed by yourself, Zach, and some other great providers, Dan included, to do maybe more than, I don't want to say more than I was allowed, but maybe more than I thought. And they don't really tell you in a lot of EMT schools, like, hey, you can do a stroke assessment or ask these chest pain related questions for, acute coronary syndrome. And heard a lot of EMTs that I work with, they're like, I was like, hey, you want to do a stroke exam quick? And they're like, I can't, like, that's out of my scope. And I'm like, you're asking a couple questions. Like, asking somebody a question is not outside of your scope. And so I think it's so important to use those initial providers, especially with that chase car model, to where they're going to be on scene before the medic in a lot of cases. And they're going to start this line of questioning. And so, no, maybe they're not throwing an antibiotic at that patient, but I can be the first on scene and ask somebody, like, hey, what are your symptoms like? Is there a known infectious process here? And then I can report it to you, Zach, right when you get on scene. And you're like, boom, I don't even need to ask these questions because I trust my providers. They've asked this right line of questioning,
Mhm.
and now I can immediately act. And so that brings me to the next thing that I want to talk about as we progress with this sepsis care, is something that's new to especially Pennsylvania EMS, but a lot of EMS systems, is Levofed, and which is norepinephrine. So Dan, you went to a pretty progressive system and you were working in Pennsylvania. Um, I know you immediately went somewhere that had Levofed at your disposal. Tell us a few of the things that you think about when using norepinephrine, not just in your sepsis patient, but in a broad analysis. And I would urge our viewers at this time, if you didn't listen to our quick crit on Levofed, to give that a go. But Dan, what's important to you with norepinephrine, and why do you feel it's important in septic shock? And then same question to you, Zach. Why are you guys using it as that first line presser? Not just because the data says to, but why is it so good at its job?
Well, as far as why it's so good at its job, we hashed that out on the last quick crit. So definitely go give that a listen. We won't beat the dead horse on that one. I like to think, especially when we're talking about Levophed and when we're talking about sepsis and septic shock, I kind of liken sepsis and anaphylaxis together. While they're different processes, they are essentially both exaggerated responses to something, right? And I think we have finally started, or at least in my opinion, I feel like we finally started seeing people having a more aggressive take to anaphylaxis or even severe allergic reactions and not being as hesitant to pull the trigger on giving IM epi. And I think we kind of need to have that same type of mentality, that same thought process when it comes to levo in our septic shock patients. And when we think about what these disease processes are at its base, they are a distributive shock. When we are thinking of distributive shock, we have that widespread vasodilation and we need a vasoconstrictor. Like we said earlier in the episode, you can throw all the fluid in the world at it. And at the end of the day, if we are in a state of exaggerated widespread vasodilation, fluid's not going to fix that. To echo exactly what you said earlier, it's just not going to cut it. We need to have that approach where we take what we have at our disposal, being norepi, to actually start affecting real physiological change in that patient. And that's exactly what we're going to see with that norepi being that vasoconstrictor, giving us the ability to then see effective change with the vasoconstrictor being levo, as well as that fluid, and then obviously with the antibiotics and everything else that these patients are going to receive. But again, if we don't start at the base and if we don't start correcting what the underlying issue, yes, the underlying issue is the infection that's causing this, but that vasodilation is also where we're going to see those hypotensive events, and those hypotensive events are what's going to ultimately increase that mortality and morbidity.
Yeah, Dan, exactly. And so, Zach, I now want to throw it to you in the pure sepsis care because you're talking about your pilot. 2 points that you made earlier was you have Levophed now and that you have it on an IV pump. I know that Bundle says we want to get that any sort of vasopressor run through a central line, which as a nurse, I agree with because I've seen what these vesicants can do, but obviously in EMS, that's not plausible. So tell us why that IV pump is so important and tell us why that Levophed is good for you guys with your pilot and also the initiation of it. When do you start to consider it? I know we spoke a little bit on it earlier with your clinical judgment, but dive into it a little deeper for us, Zach, on really the decision-making process to not only invest in the pilot, but invest in the antibiotic and this vasopressor and this IV pump, because a lot goes into this.
Yeah, absolutely. So we actually had Levophed and the IV pump for it's been a little, I think it's been about a year and a half. So this started well before this program even came to fruition. But in our state, to give Levophed, you have to have an IV pump. That's a state regulation. Um, and there's obviously a lot of pushback by a lot of older paramedics, like older, um, well, even before my time, they always used to say, "Oh, Levophed, leave them dead." But the problem with that is, I believe it's hated on similar to dopamine, right? Why do people not like dopamine? Because they titrate it to effect. Running dopamine wide open for a short period of time is going to probably cause you some problems, much as I'm sure Levophed did as well in the past. And because if you really think about it, so the first time I used Levophed, I couldn't understand why it didn't work. I had an extremely wildly septic patient, surprisingly, about a year ago. It was the first time I got to use it. Pressure 60 over 40. I hooked it up. I was running it at the lowest dose to start, and it just like, this isn't working. Why isn't this working? So I keep increasing the dose, and I'm increasing the dose. And finally, like 10 or 12 minutes into it, I'm almost maxed out at the dose that the state allows, and the pressure shoots up. And I'm like, oh, wow, what? How do we go from extremely hypotensive to now we're like borderline hypertensive? Well, there's something that my kind of slipped as I was going through. When you're giving Levophed and you're dripping it at the lowest dose Do you know how long it takes to get through an IV lock? A 2 to 3 cc IV lock? About 23 minutes. So when you suddenly increase that and you hit them all at once with a max dose of Levophed, you're gonna cause some hypertension. So putting that as part of the education point of we need to make sure A, we're putting it and dosing it correctly on an IV pump, and two, equipment wise, that you're doing the right thing, that you're running it through either directly into the IV line or you're flushing the IV lock with the Levophed, so you're giving it appropriately. Granted, you could say, well, what about a push dose presser? I think that's great. I think push dose pressers are awesome, but you can set up an IV pump with Levophed in probably about the same amount of time, and you're going to get consistent results instead of just bumping their pressure up every 5 or 10 minutes or so. Um, so I think it's just a more consistent, just kind of better option in the long term for the patient. Because again, that's one less thing you then have to worry about. Whereas if you're giving push dose, you're like, oh, their pressure went down again. I got to give them more. Nope. When it's Levophed, you set the dose. As long as that dose is titrated correctly, you're basically setting and forgetting it as well. Not only that, a lot of our septic patients, what are they going to be? Tachycardic. And what is Levophed hit? Primarily alpha one. So we're getting mostly just vasoconstriction without that increased heart rate that like a B1, something with like epinephrine or dopamine might do for you.
Yeah. And the other point you mentioned with the push dose pressors, I think they absolutely have their place in the hospital and in EMS. I
Mhm.
think it's a bridge to the IV pump. And so you made a great point. You can set it up just as fast, but when your patients are crashing, getting them a little bit of that vasopressor support, absolutely indicated. I can draw out of a 1 cc syringe my cardiac dose of epinephrine and give it as a push dose. Now, I'm not giving the whole 1 cc syringe. Let's be mindful if you're mixing it up anyway, whether you're using the 10 cc method or the 1 cc, whatever, you can get your push dose fairly quickly. However, ultimately, what that patient needs, not only to free your hands up to function as a paramedic, is that IV pump. It's more consistent. They're going to get this dose at a titratable range. It's going to continue flowing into their system and getting that desired effect. Not only that, that IV pump sits on a pole, and all that I need to do as a paramedic is, which may be harder, easier said than done, is look at my patient, assess them, assess their blood pressure, and titrate that medication to its desired range. And so I'm not just, absolutely letting it and forgetting it, but really you are. And you're just monitoring your patient. And you can do that a lot better with the IV pump than you could with a push dose, as I'm redrawing and going back and redrawing and monitoring and all of those things. I want to get into a point on Levophed from a book by Dr. Eddie Gutierrez that I carry with me all the time. So our viewers, it's the Vasopressor and Inotrope Handbook. I think it's a phenomenal resource, not just for CVICU nursing, but for anybody who really wants to dive into the deep and dirty of all of these medicines that we can give for different cardiac effects, but for systemic wise. The Sensor trial in 2019 demonstrated that initiating norepinephrine within 93 minutes of arrival at the emergency department had significant benefits, including a higher percentage of patients surviving to discharge. The previous median was 3 hours and 12 minutes in a standard therapy. There's a lot of info on norepinephrine and different trials in there, but I thought that was a great piece of data. The point I want to make with that is that was initiated 93 minutes presenting to the ED, and these patients had significant survival. Imagine what we can do if we can get that therapy initiated before the ED. Forget that 93 minutes after they arrived at the ED. They've got it on arrival. I think that their survival will go up exponentially. Now, that's completely anecdote, but Zach, I know you have some data right in front of you on how lethal, how bad sepsis is. We've talked about it all episode. Get us a little bit of down and dirty with the data on what you use to really advocate for this pilot.
Yeah, absolutely. Let me just pull it up here real quick. So obviously, like you said, sepsis, we're 1.7 million adults develop sepsis a year, and 350,000 die in the hospital. And that's just in the US. 350,000. That's so many. That's astronomical, right? That's insane. When it comes to the EMS standpoint of things, some of the data that was very alarming, very telling of the how important this is. There was a number of different studies. For example, a cohort study that was done when it comes to administering antibiotics in the pre-hospital setting reduced in-hospital mortality, with rates dropping from 47.8% in the usual care group to 32.2% in the antibiotic group. 47 down to 32 is amazing. That's incredible. Other ones that showed that early antibiotics decreased ICU stays from basically cut ICU stays in half. Another one, patients who received pre-hospital antibiotics had reduced in-hospital mortality 8.5% versus 25.5%. And if you just do a simple Google search, there's tons and tons and tons of data out there that shows that the earlier we recognize and treat sepsis, not just with patients who are hypotensive and septic shock, but patients who are meet the criteria for sepsis, the earlier we're treating them, the better their outcomes are significantly, not just by a little bit, but significantly, to the point of a lot of I think it's extremely helpful and extremely I think it's an amazing progression to see, for example, pre-hospital blood being given. It's amazing. How often are we truly using it? I know a service local to us has gotten to use it a handful of times, and it has saved multiple lives. Absolutely, without a doubt, it is saving lives across the Commonwealth, right? But that's a very small fraction of patients who get it and need it. Whereas this is one of our most common disease processes we see on a daily basis that we can be affecting outcomes for. And I think the reason you had asked earlier, why isn't we have all this data? Why isn't anyone paying attention to it? I think some of the things when it comes to the sepsis bundle and the administrative side on the hospital end has probably in the past caused some issues with EMS. Obviously, the obtaining cultures that are clean and able to be used are another proponent. And honestly, I'm going to be pretty blunt here. It's just not glamorous, right? It's not glamorous. You're not, pulling someone out of a car wreck and administering a unit of whole blood to them, and that just doesn't look heroic. Getting grandma from a nursing home with a UTI and administering an antibiotic is not very glamorous. And I think that is as shallow as it sounds. I do believe that did play a part in why this wasn't given much attention until the past few years, is because that it wasn't as cool as some of those other things. But it's awesome to me, and it's incredible how many people are finally jumping on the bandwagon of treating sepsis aggressively and early. And I love to see where this is going to go in the future.
Absolutely. And I agree with you, Zach. As we kind of wrap this episode up, I want to throw a couple questions at Dan and then bring it back to you. But the whole push for pre-hospital blood, it looks great on paper and visually, and it does save lives. By all means, it does save lives. But your traumatic patients, it garners a lot of those clicks on social and even just in meetings and pushing for it. Like, this patient got into a really bad car accident. They need blood like immediately. And there is data to prove that those patients have better outcomes. Absolutely. Like everything in medicine, it should be done with some data backup. But I unfortunately agree with you, Zach. I think that sepsis just didn't get the clicks that it deserved to be pushed out in a huge capacity, which has always been odd to me because what you said resonated so true. More than a quarter million patients we see suffer from septic shock and die. 350,000 patients die. That's more than we're probably seeing with any amount of traumatic injury, a lot of your acute coronary patients. And these patients need to receive that treatment, not just in the hospital, but pre-hospitally. They need to get it on board the same way that we started the whole ACS pre-hospital care to get these patients to a cath lab as soon as possible, right? We can read and identify a STEMI really well as a paramedic. They go through that in school really well. I mean, I read 12, I love cardiac stuff, but 12 leads is something that I make it a point, and a lot of medics make it a point to know because we want to get those patients to the appropriate level of care. Well, our septic patients need to get to the appropriate level of care. And that level of care is getting antibiotics like now, like yesterday. So, Zach, what you said is a great point. They need them, not just an hour of the hospital, but they needed them probably a couple days ago. So we need to do our job as providers and clinicians and use our judgment to get them the care that they not only need, but deserve. And so, Dan, what I want to ask you is as we wrap up this conversation on sepsis, why do you feel like it's so important? I know I see a lot of patients that are pre-septic or have septicemia that progress into that septic shock state, not only in the hospital, but pre-hospitally. It's a lot of the patients that we see. And Dan, you said you guys might not always treat it the way that Zach is now with the pilot. Why is this so important? Why are we even here talking about it? And how can we be better providers from this episode?
Well, and I think that's the whole point, right? I think bringing more and more light to this topic, doing what we can to advocate to our services, to our neighboring services, having conversations with people that are championing these programs like Zach, being able to witness him and his service bring that full bundle of care to these patients only helps us as individuals advocate to our services and to our neighbors and to our coworkers and to whoever will listen that, hey, this should be done and that it can be done. We talked about some of the roadblocks that Zach had gone up against, and we talked about some of these logistics issues. And while I know all three of us are on the page that logistics shouldn't come in the way of patient care, we also do live in the real world and understand that, sure, we do have to account for logistical concerns, but seeing this done and being able to bring to light, I'm very far, I'm half the country away. So now I can take this information that Zach is giving us and go to my service, and everybody that's listening, regardless of where you are, we can start advocating and we can start championing for programs within our own service to bring this. Zach brought up that was a 15% on the general numbers. That was a 15% decrease in death. If that's not worth it, I don't know what is. I mean, like you guys were both saying, yes, the blood and all of these other programs are phenomenal programs. We're not downing those at all. Those should all be done as well. But when you're looking at numbers like 15%, that's massive. And being able to go to our programs and say, or go to our services and say, hey, these programs are being done. Yes, they can be a headache at times. I'm sure Zach has lost a lot of sleep over trying to get through some of these steps. Yeah, it's not that it's an easy road to walk, but the data is there. And companies like Zach's and others hopefully are in the process, as well as seeing that the data is there and trying to roll these out. So I think this is so important because, again, why are we here? We're here to save lives. We're here to try to do our best to interfere in that disease process chain of whatever it is that's going on. And you both have said this, so I won't repeat it a ton, but this is one of the most common disease processes that we will see. And this is one, we've said this in every episode as well, early recognition, early detection, and early intervention, regardless of what it is that we're talking about, saves lives. And the data that we have here just simply proves that.
Yeah, Dan, absolutely. Zach, we really have, I think, beat this sepsis thing down pretty hard. First and foremost, I want to thank you for not only pushing to get this pilot out to the Commonwealth, but I want to thank you for taking care of the patients that suffer from sepsis and septic shock, because it absolutely needs to be done. And in the pre-hospital setting, it, like everything that we kind of are fortunate to start getting now, probably should have been done a while ago. So thank you for taking the initiative to treat these patients and push for it. And secondly, thank you for coming on to the podcast today to talk about this, because it is so vitally important. And so
Absolutely.
with that being said, Zach, what do you have to leave to the people that are viewing on our YouTube or TikTok, and also the people that are listening on all the channels that we broadcast to, what do you want to leave them with as far as this sepsis pilot goes? But not only that, taking care of these patients, because we see probably way more of these patients than we even think.
Yeah, absolutely. I think looking at the 15% and looking that on, if we take that to a national level, if we're saving 15% of the 350,000 people who die from sepsis, that is over 52,000 people a year who potentially could survive sepsis. 52,000 people is a staggering number.
Hmm.
And I think just taking that, and if you're passionate about something, mine was and has been for a while, has been sepsis, because I knew how many people were dying from and how common it was. If you're passionate about something and you want to do something and move the needle to further not just the industry of EMS, but healthcare in general, and make the job better, do better by your patients, then do it. Then put your mind to it. Be patient. Again, this has been 16 years in some capacity that I've been trying to do this in some way, and it took 16 years to make it happen. And I believe it's going to pay off tenfold, and this is going to echo into the future for a long time. The people we're going to be able to help because of this. And I was very fortunate by a very supportive team, a very supportive director, a very supportive regional MAC committee and a state committee. And I can't say enough how many folks were so supportive and helpful throughout this process. And it is truly a team effort. And we could sit here and say that yes, it was kind of my silly idea, but it required so many people to make this possible, make this happen, that I can't even thank them enough, and thank folks like you too, who are making an effort to make our job better, and going on here and doing something like a podcast to teach and educate in a way that's a bit atypical, that is coming around in the past few years. Doing podcasts in a training fashion has been awesome and is very cool, and you guys are doing a great job. But to kind of leave it with everyone is this is huge. Like, this isn't, again, I know it's not glamorous, but this is truly going to help a majority of our patients. And anyone who might be interested in some of the research and the data, and maybe you want to try to do something at your home agency, feel free to reach out. And I would like to help as many people as they can, potentially make this happen wherever they can. Because, like I said, this is going to be huge, and I'm very excited to see where it goes.
Zach, thank you so much. We loved having you on here. Dan, anything else you want to close out to our listeners?
Nope. Just again, huge shout out to Zach. And I know that's a very humble thing to say, but we do need a catalyst. And you were the catalyst, at least as far as your service goes, that spark that got the ball rolling. So that is absolutely huge. Don't be afraid, if you're listening, don't be afraid to be that catalyst. Don't be afraid to push that boundary and try and step out of your comfort zone and get the ball rolling. Be that spark that brings what Zach has said is a huge difference maker to potentially your service.
With that being said, Zach, thanks so much for coming on, and we will catch you guys on the next episode.